Well, good afternoon, everyone. I'll just wait a couple of minutes for people to join. I know that the audience is usually more discerning, smaller for pure hemopath compared to general pathology. Next week, it'll be my colleague Sidra, who will be talking on pancreatic pathology, particularly pancreatic cytology. So that's an area that people don't get a lot of exposure to, but obviously it's very important. I think I'll wait till 5 past, just so that we can get a kind of quorum of people. So also this week, this will be the last Hempath session. Then next week, got, like I say, pancreatic pathology, and then we'll be having a summer break. And we will resume on the 3rd of September. We'll actually be in. So we'll resume on the 3rd of September to kick it off. So I hope you all have a nice break, but still a couple of weeks to go. Right, okay, it's 1:30 now. The other thing I'm going to try and do today is I'm going to go through some Trefine cases, and also I'm going to share with you this here. I don't know, can you see that now in my share?
Not yet.
Let's see. Yeah. So I'm gonna go through this, and I'm really keen for the audience to tell me whether it would be useful during the Hempath sessions to do a few Trefine cases and then use this Hempath Atlas, which is on the University of Leeds website, to start going through some lymph nodes as well, because obviously I've not done a lot of lymph nodes, and I realize that we should do more. There's a lot of material in this collection. So over the space of, say, 1, 2, 3, well, each one of them has got a huge amount of stuff in it. So each one could probably be spread over 2 or 3 weeks to go through it. If we just did a few cases, and we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So we've probably got at least, if there's 11 of them and we split them into 2 or 3, we've got between 22 and 33 weeks worth of material there. Obviously we got Hempath for 20 weeks of the year. So starting in the autumn term in September, if the audience think that it'll be useful for us to go through those as well, the questions and answers, that will be helpful. Anyway, I will stop a few minutes early at the end to gauge your enthusiasm for that. And in the meantime, I will go back to today's set of cases, which my colleagues have provided for me. And it's always quite a complex task to juggle the multiple screens whilst controlling the microscope as well. So I'll just move that so that it looks like I'm looking at you. I'll just move as the microscope is slightly to one side. Okay, right, so my head might move around quite a bit now. So I'll go through some of the teaching cases that my colleagues have put aside for me. I'll not start with that one. So I'll start with this one. This is an interesting, I've got a couple of interesting cases here and points for discussion. So this one is a 45-year-old man, and he was diagnosed with an acute leukemia in November 2022, so coming up for 3 years ago now. He had an allograft, and this is query relapse. And I'll go through the details of his leukemia as we go through the slides. So it's always important to know what the full blood count shows. So his hemoglobin is 91, white blood cells 1.5, so that's pretty low, platelets 59. So, and there were no blasts in the peripheral blood, though of course we know that you can always get recurrent disease in the marrow before it represents into the blood. So, 45-year-old, a bit of a disrupted and hemorrhagic marrow. With controls correct. Slightly disrupted and hemorrhagic marrow. So suboptimal, I would say. Certainly okay in terms of length. The trabeculae, they do look a bit thinned actually for someone aged 45. This here in particular looks thin, and this one here. I wouldn't worry too much if there was just one small area, but you've got a small one there, thin area there, thin area there, thin area there. So I mean, he's had an allograft. He's probably had lots of rounds of intensive chemotherapy over the last few years with his acute leukemia and then transplant, so that might have affected his bones. So this is the marrow. I think the cellularity for someone of his age is adequate, but we know he's cytopenic. And I think at this power, let's try and get it in focus nicely. It does look to be slightly monomorphic, the population of cells. It doesn't seem to be a nice range of hematopoietic cells. We've got occasional erythroid cells, but then in the background, large numbers of kind of medium-sized monomorphic cells. So particularly this area here shows it well. So we have got some residual erythropoiesis here. There's probably, I don't think in this field, there may be, yeah, there's some megakaryopoiesis in this field as well, but there's virtually no normal myelopoiesis. I can't see any neutrophils, maybe one there, and that's it. And then we have all these monomorphic pale cells in the background. This is the highest power that I can go to. So I think there is, and again, we've got them here as well, these slightly irregular cells spreading out all the way through the marrow, very little maturation. It doesn't look like just left shift. If you had a left shifted marrow without maturation, that would have to be in the context of recent treatment, but his transplant was a couple of years ago now. And also when you get left shifted cells, they're much more immature than this. These just look monomorphic, slightly immature, and all the same. So we've got immunohistochemistry. So we'll see what lineage they are, which is important. So here we've got myeloperoxidase. So the majority of them are, there's focal myeloperoxidase positivity, but it's relatively weak. Okay, so we've got weak and granular myeloperoxidase positivity in the majority of the cells. Some of the cells are more strongly positive, but the majority of cells in the background are more weakly positive with this granular staining. Also got an erythroid marker. So this is E-cadherin, and this demonstrates, well, it's a bit of a dirty stain actually. I think there's actually, I think a lot of this staining is artifactual in this one. So I think that these areas here are artifactual. I think that we have occasional E-cadherin positivity, like here and here. These blobs, I think, are not actually cellular. So we've got focal E-cadherin positivity. To look for blasts, we've did CD34, and this actually shows it's positive in the majority of cells. So it's always quite granular staining, CD34. So in this area here, you get this granular kind of like punctate dot-like staining, often around the edges of the cells. And my colleagues who reported this case, they estimated it about 60% positive. So about 60% of the cells positive for CD34. So increased blast count. So I think it's a recurrent acute leukemia. We know that it's weakly myeloperoxidase positive. 117, I think 117 was reported as weak. So quite weakly positive. A lot of this is background staining, in fact. But there is weak positivity for CD117. The interesting thing was the we also did T-cell markers. Given that the myeloperoxidase, so we did B and T-cell markers, given that the myeloperoxidase was only weakly positive. In fact, they didn't do B-cell markers, they just did T-cell markers. And this is the CD3. So you have to be careful interpreting the CD3 because it would be possible to just look at that and say, well, there's just a lot of reactive inflammatory cells. But this is positive, I think, in the blasts. So you've got these notched cells all over the place. And this is about the same. This is too high a proportion, I think, for it to be just an inflammatory infiltrate. And a lot of them are quite irregular. They have the same size and shape as the CD34 blasts and the same size and shape as the weakly myeloperoxidase positive blasts. So here, for instance, this one here, this one here, this one's through here. I don't know if there's anything. So if anyone's got any points to make in the chat, just put them in the chat, please. It's quite difficult for me to follow the chat whilst I'm going along. I have to look at too many screens. So Ava, if anything comes up in the chat, just alert me, please, and I'll stop.
Definitely.
So we've got CD3 positivity. Also, this is even more convincing, I think. The CD5 positivity, you can see really nicely that these don't look like normal lymphoid cells, got a prominent nucleolus. I think in a reactive T-cell population, you might expect maybe, a few cells to have a bit more of a transformed morphology. But in this case, like nearly all of them have. So it was positive for CD3 and CD5, as well as for myeloid markers, particularly CD34 and myeloperoxidase. I'm not sure about TDT. Let's see if TDT was positive. We also did a CD4, but that was uninterpretable, as is often the case with CD34. I don't find it particularly helpful marker. Yeah, so it's TDT positive as well. And there is some background staining, but it's clearly got clear nuclear positivity. So this was reported as a mixed phenotype acute leukemia, T-MPAL, so T-cell mixed, T-cell myeloid mixed phenotype acute leukemia. And that was that concorded with his initial diagnosis, actually. I didn't put that at the start, just to keep your interest level up. So you can never be too sure with an acute leukemia. This is the CD4, for instance. Well, is that interpretable? I'm not sure. I think you have got occasional cells which are a bit darker, like this one here, these ones here, but generally that's not interpretable. So the diagnosis here was of a mixed phenotype acute leukemia, T myeloid, which was the same as it was in 2022. So unfortunately, this has relapsed. But it's important to, have to look at the criteria for diagnosis of the MPALs. So if I go to that, if I see if I can find that, monoproliferations. So if I stop that share and go to the share here. Right, so looking now at the WHO book, we've got one in the chat. Yeah. How to suspect an so in answer to Vinoth, there's no real way to, in my experience, to suspect these except by doing the markers. So all our cases have flow cytometry as well as immunohistochemistry, and so the flow cytometry could well pick it up. But of course, that's very dependent on knowing which markers to put in to the flow cytometry panel. So if you don't put any markers in, then you're not going to get any results. So it's important with an acute leukemia to consider myeloid markers, T cell markers, and B cell markers. Otherwise, you simply won't make the diagnosis. Are the cells smaller than usual? These ones are kind of like medium sized. If we go back to the H&E, are they smaller than normal? I don't think so. Maybe they don't show as much in the way of differentiation, actually. Yeah, I think that's one, maybe that's one clue. Obviously there's much nicer section, actually. Yeah, so they do look maybe a bit smaller, a bit more uniform compared to most acute myeloid leukemias or lymphoblastic leukemias. Obviously, no myeloid differentiation or very little myeloid differentiation to neutrophils. And most acute myeloid leukemias, a lot of them will have some form of differentiation, not a lot, and a bit more pleomorphism in the blasts. Otherwise, I think the only way to suspect it is to do the range of markers. So in our practice, because all the cases have flow cytometry as well as immunohistochemistry, we don't routinely do a wide immunohistochemistry panel. If I just show you the number of markers, so we did we did all of these markers, all of these slides for this case, which is quite a lot of immuno. So we wouldn't routinely do that number of immuno because we've already got the flow cytometry. But otherwise, I think that's the only way. In terms of going through the differentiation, the diagnosis. So for a T, this is in the new WHO 2015 classification, number 5 classification. So mixed phenotype acute leukemia T myeloid. So my colleagues actually call this something slightly different. They actually called it T MPAL, whereas in fact more properly it's called T myeloid. So you've got to have mixed T and myeloid markers. So you really need to have a number of them, not just one, because you can have one expressed as an aberrant marker. So CD7, 2, 4, you need to have all of, you need to assay all of these because you don't know which one's going to be present. And then go through the myeloid markers. So CD33, CD34, CD117, myeloperoxidase. There's no other way to make the diagnosis. So this was a T myeloid MPAL, mixed phenotype acute leukemia. And now I'll come on to the next one to continue the discussion. Excuse me, I have to make sure I keep everything in order because I've got a lot of cases and they're all from different people. And then you all need to go back to different colleagues. So it can be very confusing. So bear with me if I go to the next case. Was that okay, Vinod? I know it wasn't maybe the answer you were looking for, but in my experience, you've just got to do a range of markers. Most of them will be positive for CD3. So I think if you do CD3, CD79A maybe, along with the myeloid markers, that should get most of them together with a TDT. But there may be some fall through the net, but that'll probably capture most of them if you have to restrict your number of immunos. Right, this is another case of acute leukemia. This is a 70-year-old man, and he progressed. So he had primary polycythemia and a worsening cytopenias. I don't know what his counts were. He came from an outside hospital, so we don't know. I don't know what his full blood count was. So they wondered whether this was progressing to a myelofibrosis or a acute leukemia. So he's got polycythemia, which can progress to myelofibrosis. Interesting in this case. Let's go to lower power. So my colleagues are giving me tons of cases here, actually, which I'm not going to get through all. So I need to remember to put them aside. So I've got some to start with next year. Of course, on the 3rd, when I recommence, I'll actually be in a meeting in Oxford, but I will cross that bridge when I come to it. I'll work out a way around that. Okay. So it's an adequate biopsy. It's hypercellular for someone of this age. Interestingly, his bones don't look quite as bad as the other one, actually. So it is important to look at the bones. I think I said the bones were normal. Looking at the cells, these ones do look larger than the other one. That's horrible, that, isn't it? Let's just auto white it on a good area and then move it back in. So we've got megakaryocytes, occasional small erythroid clusters, like here, and then this very marked population of medium to large blasts scattered everywhere with no differentiation, and they look the same most of the way through. They're quite large. Some of them do look erythroid, so it's arisen out of a background of polycythemia. So there's always the worry that this is a erythroleukemia, and then of course there's also the question as to whether it's transformed to myelofibrosis. It doesn't seem to have a particular streaming aspect to the cells, but given the question of query myelofibrosis, you need to look at the reticulin. And this is the reticulin. So, as I've said before, we counterstain them with a trichrome stain, which is like purpley pinky for the collagen. It's present obviously in the trabeculae, but not in the marrow spaces. I think that this is a fine network of, a network of fine fibers like here, and occasional coarse fibers like here. So the WHO classification of reticulin is that fine fibers, such as here, equate to grade 1, and additional coarse fibers like here, grade 2, and you need collagen fibrosis within the marrow, usually accompanied with osteosclerosis, to call it grade 3. So, oh, sorry. Let me go back. I've just seen that. I apologize. Hopefully you're still with me. You've not lost patience with me. Is everyone still here? No one's dropped off, Ava, have they?
No.
Good. My apologies. Let me just try and stop that share. Okay, we're back to this. Right. Well, you've heard me talk about this now, so now you can actually see it. She says I probably need a summer break as well. Anyway, so here we have the biopsy. It's an adequate core, hypercellular for age. I've said about the bones, they look normal. Going in at higher power to see these cells. So I don't know, maybe it's good for, so Ava, if you're able to, so I think people said that they couldn't see it. I don't know if someone could be made a kind of spokesperson in case I can't see anything. Either yourself, Ava, or someone else, because I couldn't see the screen then, so I just need to be alerted because I'm
Yeah,
not.
absolutely.
Is
It's
that
sharing
okay?
now. Yeah, of
Yeah.
course.
Because basically I've got all the clinical information and the controls on one screen, and then the image we're looking at on another screen. And yeah, so we've got these blasts spread right the way through the marrow, quite uniform. We have got some erythropoiesis. So as I say, we're worried that there may be erythroleukemia because it's risen out polycythemia, and also worried that there may be myelofibrosis. So looking at the retic, as I'd said before, to show you now, a network of fine fibers, such as here, would be grade 1. Just occasional fine fibers is grade 0. It's normal. And additional coarse fibers. So you've got to scoot around a bit here to see the coarse fibers, but there are in places coarser fibers, like this is quite a coarse fiber here. That pushes it up to grade 2. And you need additional collagen fibrosis, so actually purple staining within the marrow spaces, for it to be called grade 3, which is usually accompanied by osteosclerosis. There isn't really any grade 3 here. The kind of thing you'd be seeing in grade 3 is a purplish stain within the marrow. So this purplish stain here and this purplish stain here, this is simply because it's around a blood vessel. But if that purplish stain was associated with the rest of the increased reticulin, then you can say it's up to grade 3. Of course, early myelofibrosis can well be grade 2. So the fact that the reticulin doesn't get to grade 3 in this instance doesn't exclude a myelofibrosis. So we're worried about the lineage of these cells. Are they myeloid? Are they erythroid? What are they? So I think that on H&E it's very difficult to tell. On H&E, you'd probably say these look erythroid actually. And you probably go for erythroleukemia on H&E alone. Because they're quite large and they look a bit erythroid with these prominent nucleoli and clear chromatin. But we can look at the immunos. And this again is one where we did multiple immunos. So this is the myeloperoxidase. And in similar to the other one, we've got some strongly positive cells and some more weakly positive cells. in the background. So again, there was a bit of a worry here that this wasn't just a straightforward acute myeloid leukemia because of the distribution of myeloperoxidase. CD34 so CD34 is often a weak stain, but you can see very strong, very widespread positivity for CD34. I think they were also positive for CD117 in contrast to the last one. Yep, so it's weak, but I think this is definite positivity in these cells here. So we got myeloperoxidase, some weak myeloperoxidase, very strong and widespread 34, some focal one and weak but widespread 117. It's also positive for CD33, but that's a stain that is often positive everywhere. But then in this case, we also looked at a range of B and T cell markers. So it was negative for CD3. This is CD3. And you can see that there's a scattered population of cells. Now you might say, well, that looks quite similar to the one you showed me last time, Richard. Except that I think these are more uniform small cells. And these larger notched cells are not positive, whereas in the other one, those atypical notched cells were positive for CD3. TDT, we did TDT, and this is strongly positive. In fact, it's so strongly positive. You might say, well, you just showed me the same cases before again. No, this is a different case, but it's TDT positive. So you can have aberrant TDT positivity in acute myeloid leukemia. But in this instance, we also had, this is CD79A. Now we have got infiltrating B cells, which are strongly positive, but there's also weak positivity in the background, atypical cells. These cells are weakly positive. That together with the TDT, which is very strong, makes me wonder about, again, a mixed phenotype. I think on the TDT alone, that wouldn't be enough. We also did a PAX5, which is a bona fide B cell marker, and there's lots of PAX5 positivity here. And you can see that the amount of PAX5 positivity, which is nuclear, is greater than the number of possible B cells. If you just take the strongly positive 79A ones, and I think, yeah, and it was negative for E coherence, so it wasn't an acute erythroid leukemia. So there was debate about this one, and to start with, I said there's virtually no myeloid maturation. There was also increased megakaryopoiesis. So I think that on the H&E, you can see that the megakaryocytes are increased. So these are two complex cases. That's why I'm spending so long on them. And I think the acute is really important to, first of all, for me to give the message about them, also to be reminded myself, but for everyone always to consider, if you've got an acute leukemia, could it be mixed phenotype? Because obviously, if it is and you miss it and they get one line of treatment, either lymphoblastic or myeloid, then it is going to relapse relatively quickly with the other lineage that you've not treated. So if you give it myeloid, the lymphoid will come back. If you give it lymphoid, the myeloid component will come back. So I said there's quite a lot of megakaryocytes. So here they are. There's that one there, another one down here. This is slightly atypical. And when we looked at the CD61, there's quite a lot. There's a lot of megakaryocytes, and they are atypical. So we have higher power, got lots of small atypical megakaryocytes, abnormal staining. That's not quite a cluster, but we've got clusters elsewhere. Lots of micromegakaryocytes, like this one here, these ones here, that one there. Lots of atypical clusters, in particularly like this. So those probably favor it being overall myeloid rather than MPAL, because it may have arisen out of with a degree of early, pre-existing dysplasia. So when I looked at this, I said it's got myeloperoxidase positivity, CD117, TDT. That makes it myeloid. Myeloperoxidase, CD34, and CD117. That makes it myeloid. It's also got TDT, 79A weekly, and PAX5. I think the 79A on its own I might have not taken attention to, but it had PAX5 as well. I thought that looks B. So I reported this as a possible MPAL, the other type of MPAL. If I get back to the WHO. So the other type of MPAL, which is mixed phenotype B myeloid. So share that one. So I thought it might be this one. I thought it might be a mixed phenotype acute leukemia B myeloid. And it did seem to fit the bill for that. So it's got B lineage markers, so 79A and PAX5, and also it's got a range of myeloid antigens. Stop that share so I don't forget next time. My colleagues discussed it at the MDT, and I think based on they actually looked at the flow reports. I haven't got the flow cytometry in front of me for this case, but they looked at the flow reports, and based on the flow cytometry, the B cell markers were thought to be very, very weak and only a very minor population, and they didn't think that it amounted to an MPAL, but it was important to consider it. But they couldn't decide just on the immunohistochemistry, and we couldn't decide just on the flow cytometry report. They actually had to go back and look at the actual flow plots to say, well, yeah, there were some cells positive, but they were a different population in terms of size and shape to the myeloid population, and therefore we didn't think that it was mixed lineage. So complex case. Running out of time, aren't I? I've got another two particularly interesting cases to show you. And then I'll maybe have a look, then we'll quickly have a look at this Leeds website. So, which one is it I wanted to show you? That one. That one. Right, so this one is a 70-year-old man. Actually, sorry, just bear me through. I'm just getting the cases together here. Yep. Okay. Right, 70-year-old man, and he's got cutaneous mastocytosis. So the question here is, has he got systemic mastocytosis? So this is his marrow. Well, I thought I had two of these cases. My colleague had a case of this with an associated hematological malignancy, but she's not given that to me. I might just see if she's got it. for me to show by comparison when I go through this. Once I've gone through this one, let me just send me an email. Okay, so it's a 70-year-old man with cutaneous mastocytosis. He's obviously got a hypercellular marrow for age. Let's see if my colleagues replied to me. No. A hypercellular marrow for age. And there's also bony abnormalities. So you can see at this power, the bones are sclerotic. There's also quite a lot of woven bone, like in here. So we've got woven bone, got extensive cement reversal lines indicating successive waves of new bone formation. We've got thick osteoid seams, like here and elsewhere. So we've got ongoing and abnormal bone formation, which indicates a likely infiltrate of abnormal cells, which are producing growth factors. So mast cells, that's exactly what mast cells will do. We've also got these spindly areas like here and here. And looking around the rest of the marrow, a spindly area here, down here, here. So even on H&E, it's very suspicious for mastocytosis. Again, areas like this, spindle cell kind of morphology to the cells, like through here. Let's find other ones. And large areas like this here. So is this systemic mastocytosis? Well, lots of spindle cells. There are some eosinophils in here as well. Well, that's not very good, is it? Let's just also balance it better. Yeah, eosinophils in here as well. So I think that in terms of seeing the mast cells, it's good in this instance to look at the Giemsa, because mast cells will show up nicely on that. So this is the Giemsa, and you can see it really nicely. So you don't need immunohistochemistry necessarily. So we've got lots of mast cells showing really nicely on the Giemsa, and lots of them are spindly. So we have got two of the important criteria, going back to the WHO, for the criteria for mast cells. Yeah, she's going to bring it around now. She probably doesn't know that I need it right now. So the criteria for systemic mastocytosis, you need major criteria and minor criteria. I'll go into that in a minute. But certainly those criteria include aggregates of cells greater than 15. Well, there's certainly more than 15 there. And also at least 25% of them having a spindle cell morphology, which we've also strongly got. Yeah, we've also got eosinophils in there as well. So I think that the GIMSA shows it really nicely. We can also show it in a more sophisticated way, but probably effectively no better by looking at mast cell tryptase 117. So this is 117, and you can see very strongly these aggregates of spindled cells. Let's come into focus. Yeah, so they're all spindly mast cells, and mast cell tryptase is a little weaker. So, but it
Richard,
is
can
positive.
you share your screen?
Oh, am I still not shared?
Not right now.
I thought I was shared. Okay. Let me go back then. I don't know where I stopped. I don't know where people lost me. Okay, so this is the thanks, Ava. This is the H&E. I think people have seen this. People seen this?
Yes, I can see that.
Yep. So we've got these spindle areas right the way through the marrow. Lots of spindle cells, which are abnormal. I think the diagnosis is probably, you can establish just from that really. But then looking at the GIMSA, you can see the spindle morphology of the cells. So at least 25% of the cells are spindled and forming aggregates of at least 15 cells. And we can also demonstrate that on CD117. So that shows it really nicely, and also the extent of it. So I estimated it at between 5 and 10% of the marrow involved. And that highlights the spindle cell nature of the cells once again. And then mast cell tryptase was weakly positive 2. Yeah. And the final stain we did was CD2, which is a T cell marker, but can be aberrantly expressed. So we've got nice normal T cells here as a control, and then weak positivity in the spindle cells, the mast cells, just off to the edge. So this is a case of systemic mastocytosis. We just remember to flick between the different screens now. So the criteria for mastocytosis. So the diagnostic criteria. So you need infiltrates of mast cells and the at least a couple of the minor criteria as well. So we've got 25% of the mast cells are spindle shaped. We've got positivity for CD2 as well. What I didn't tell you is that this patient has also got a c-KIT mutation. So it's a good going case of a Systemic mastocytosis, right? I will try and find the Zoom controls. Okay, they're here. So I'll stop that share and I'll go back to sharing the screen. And I'll show the final case, which I'll just go and get from my colleague, which will take me like literally 30 seconds. Okay, so now we come back to the final case. So this is a man born in 1952, so that makes him 73. He's got a known history of MDS. He's on EPREX, which is, I think, an erythroid growth factor. Yep, to maintain his hemoglobin, now losing response, and his mast cell tryptase level is also elevated. So, just check am I sharing correctly. Yep. So I've not actually seen this marrow, so hot off the press to me. And this is even more kind of, yeah, so it's interesting, this one. So I think just like the other one, we have these spindle cell areas, like here and here. So maybe the spindle cell component is not as prominent in this one. Let me just see what my colleague estimated it at. Yeah, about less than mine. Mine was 5 to 10, and they thought 5% for this one. So there are spindle areas. You can kind of see spindle areas like here, but there's also a lot of megakaryocytic atypia, in particular in the background, like here. Very, very atypical megakaryocytes. I think the erythroid and myeloid series are also dysplastic in this case. So looking at the special stains, in this case, the mast cell tryptase is not very prominent, actually. 117. So 117 indicates mast cells more than the mast cell tryptase. So we've actually got fewer than in my case, but again, lots of them are spindly, at least 25% are spindly. I'm not sure if they're positive for CD2. We shall discover that right now. Yep, so they're strongly positive for CD2 as well. And the Giemsa so the Giemsa again is not as good as the first example I showed you. Anyway, this patient does fulfill the criteria for mast cell for systemic mastocytosis, but also has background myelodysplasia. First of all, they've got a diagnosis of myelodysplasia and also looking at, for instance, the CD61 in particular, which is a really good marker of myelodysplasia. You've got large numbers of atypical megakaryocytes, obviously massively increased with clustering, and lots of small micromegakaryocytes, which are a fairly hard sign of myelodysplasia. So this is an example of systemic mastocytosis with associated hematological malignancy, which is a separate subcategory in the WHO. Okay. Thank you very much, Yvonne, and the rest of you. I hope that was useful. I didn't get around to looking at the RC Path cases. I know people have to go on the hour. So with the remaining couple of minutes, first of all, please join and encourage your colleagues to join next week for pancreatic pathology, which is a really good area to see. And just quickly, if I have in the chat a show of hands for how many people think that we'll just carry on with the same format of trifines, where of course we've got tons of them to share, or intersperse the trifines with lymph node work based on the Leeds website. And I could either do that half and half for each session, or split my weeks, 1 week trifines, 1 week lymph nodes. So what do people want, please, in the last minute or so before we finish? And I'll be led by you. Okay, so Naji Mungai, is that for maybe if in the chat, if you, so do people want lymph node 1 week trifine second week, or lymph node and trifine half and half each second week? So which do people want? Option 1 is lymph nodes first week, trifines the second week, or option 2 is half and half. So option 1 will be, let's see if I can copy that and put it in there. No, option 1 is alternating weeks, lymph node versus trifine, or option 2 is a mix of each heme path week. So which do people want in the chat? Option 1, okay. Anyone else? Option 1, okay, great. So in future, there'll be trifines every 4th week, and lymph nodes every 4th week. Yeah. And so it'll be alternating speaker, external speaker, lymph nodes, external speaker, trifines, external speaker, lymph nodes, external speaker, trifines. Is that acceptable to the majority? I've got 2 answers, but I'll go with the majority voting, particularly as I know that Edgar in particular, is a very long-standing attender, and Yawali. I think it'd be better for me as well. Okay, well, thank you very much. And I hope you have a good afternoon, morning, and evening, wherever you are in the world. And I look forward to seeing you all again next week. I hope it's useful. I'll put my email in here if anyone wants to give any feedback, because I do value it. So I'll just leave that up there for just a moment. If anyone wants to send me any feedback, though, you can always contact Ava via Diagnexia as well. I also thank Ava for her help today, as always. And thank you. Okay, so I'll leave it up for 1 more minute. Thank you very much, Ava.
Thank you so much.
Okay. I just need to remember to keep on top of the screen sharing when I'm moving between things, but I will get slicker. Okay, I will let you all go and see you all in a week. Thank you.
Thank
Bye now.
you. Bye, everyone.
Bye.
Thank you.